A stereotactic program. Are you prepared for it? How will you monitor it? Can you improve on it if you already have one? These are questions that Standard Imaging can help you answer as we partner with you on your stereotactic program journey. Hi, I'm Andrea Zenz, one of the product managers here at Standard Imaging. Today's webinar will address how a QA complete stereotactic solution can help you meet clinical goals, especially in terms of simplification and standardization that improve efficiency, patient safety, and clinical experience. Just a wee bit of housekeeping before we get started. This webinar is being recorded and will be available on our website soon. If you want to ask questions, please use the Teams Q&A dialog box. And lastly, if you wish to enjoy the webinar in your local language, please use the live caption option under the More tab, as shown here on the slide. So let's get into it. As you well know, there are many guidelines, task group recommendations, codes of practice, regulations, and so on related to stereotactic programs. Since the AAPM RSS Medical Physics Practice Guideline 9A was developed to provide appropriate minimum standards for LINAC-based stereotactic services, let's start there. As noted in this report, the high dose per fraction and the critical importance of targeting accuracy, SRS SBRT services require a strong commitment by the radiation oncology program and the facility to provide appropriate resources. Both the clinical team and the institution's administration must understand their roles and commitments in this regard prior to implementing SRS and SBRT services. Resource commitments are vital to your stereotactic program to meet clinical goals while limiting risk and emphasizing patient care and safety. These include enough properly trained and certified personnel, such as radiation oncologists, medical physicists, dosimetrists, and therapists, so as to provide enough time for all to safely perform their work. Appropriate equipment to support the treatment process. That'll be your LINAC, your imaging, your treatment planning, SGRT, and IGRT systems. And as well, you need the appropriate instruments and QA devices, software, to ensure proper safety and functioning of all that said equipment. Clear operating procedures with delineations of duties, and certainly a safety culture rooted in transparency and process analysis are all required to really have a highly successful and safe stereotactic program. And since I'm probably likely mostly speaking to qualified medical physicists here, it absolutely goes without saying that you play a vital role in many of these resource recommendations. MPPG 9A goes on to specifically outline 10 key responsibilities of qualified medical physicists. I've only listed a few of these here since this will basically be the focus during the rest of the webinar. Since these responsibilities are directly linked to many departmental goals like patient safety, patient throughput, and clinician experience, it's our job here at Standard Imaging as your partner in all things QA to help you meet these goals safely, efficiently, and effectively. In other words, we're here to help you simplify to standardize. MPPG 9A provides a list of essential instrumentation for needed to complete a variety of QA tasks. Our robust QA complete stereotactic portfolio helps not only meet the instrumentation and recommendations, but also help you prepare and monitor the various aspects of your treatment delivery system as described in the section on simulation planning and treatment, particularly as it pertains to mechanical accuracy, localization, IGRT, and SGRT. So let's delve into what all this QA complete stereotactic actually means. The first recommendation is to have redundant, so not just one, radiation detectors suitable for small fields. That sounds simple, yet we all know that dose delivery to small fields poses a variety of challenges, such as physical size issues. We are talking about 4 to 40 millimeter field sizes. So how do you define that field size? Is it with JAWS or full width half max? What about decreased output and alignment? A small alignment can equal a large geometric and dosimetric miss. Scatter from primary collimator and flattening filters that is reduced at small fields, but small enough fields also reduce direct beam fluence. The equilibrium condition, equal lateral scattering distance equal to or greater than the range of electrons. So what are the practical implications of this? You may start losing lateral equilibrium when the beam width is less than 2 times Dmax. Higher energies lose beam plateau sooner. Detector positioning, perturbations, and so on come into play sooner for higher energies. It's important to characterize profiles, not just output factors. Once you have an understanding of your small field challenges, your next question is, how do detectors impact measurement? For instance, the detector size and shape. Volume averaging effects are of concern. So you need to ask, what is the field profile versus the detector's spot size or volume? Also, how accurately can you determine beam penumbra? Consistent and accurate position of the detector can impact your measurement. This is an important consideration when choosing a stereotactic phantom as well, and where our Lucy phantom family features provide solid benefits to the user. Perturbation of the beam. Fluence is perturbed at the point of measurement. So ask yourself these questions. How large is the air cavity of my ion chamber? For diodes, is there a built-in compensation? And how does the response vary with energy? There are some published corrections available, but then you need to be aware that you must match those published conditions in order to use those factors. Signal. Keep in mind that for ion chambers, the signal is proportional to the collecting volume. Signal to noise ratio becomes more of a concern as signal decreases, and small signals require an appropriately sensitive electrometer. Signal to noise ratio can be impacted by leakage, proper electrometer warm-up, or even triaxial cable effects. It is therefore important to match signal strength to the proper electrometer range as well. Accuracy. So what are those questions? You need to answer questions about the detectors you want to use for those small field measurements, like, does it have energy dependency issues? Does it have angular dependence issues? And what are the implications in different orientations? Are there dose rate or dose per pulse dependencies? What else might be of concern? Leakage, drift, repeatability, resolution. Can it be calibrated? Good grief, I'm so glad I'm not a physicist. You guys have a lot to consider. But fortunately, we are obviously here to help you. It's one of our core strengths. Detectors is absolutely one of our foundational core product families. And we have excellent choices for you to consider for use as part of your stereotactic program. So what are these? Let's start with our D1V and D1H diodes. They are unshielded and have a 1 millimeter spot size. Let's move on to the 826, which is just a phenomenal detector. It's the only reference class micropoint ion chamber on the market. It has a spherical volume, so orientation is not a problem, of 4.3 millimeters. It's made entirely of low Z materials so that you end up with a predictable response curve. So basically like using a farmer chamber, but for your smaller field sizes. And last but certainly not least, we have our W2 scintillator. It is the only detector with a 1 by 1 millimeter resolution and a KQ of 1. No correction factor needed. And those characteristics, as well as the fact that it is waterproof, I've had plenty of physicists tell me face to face that they have come to realize that there's no way that their stereotactic program would be complete without the W2. So as per MPG 9 instrumentation guidelines, you will also need a high quality reference class electrometer that is stable and that can be calibrated. Whether it has the range to match the signal of your detector, its warm-up time, and the number of channels are also important considerations for selecting the electrometer that is right for your clinic. Last but definitely not least, pick something with a good warranty. A good warranty with electrometers says a lot about how dependable you can expect that device to be. And with both our Max and Supermax options, they have a 5-year warranty. The Max 4000 Plus is our robust single channel electrometer. It is, of course, reference class, and many of you are aware of that workhorse electrometer, incredibly stable and reliable for years. Some of you may be less familiar with our 2-channel option, which is the Supermax, which is also a reference class, of course, and has the advantages of a touchscreen display with intuitive navigation. It's got 2 channels, independent biases for each, and it has only a 1-minute warm-up time. Now, not specifically part of the instrumentation list, but definitely necessary for commissioning those small fields and continue monitoring of those small fields, you'll need a 3D water scanning system and potentially a 1D tank as well. All of the detectors I mentioned previously, including the W2, are waterproof, so are easily suited for use in our DoseView 3D and 1D tanks for TG51, TG106, TRS 398 protocols. Both water tanks use the same DoseView software, and generally we get excellent feedback on just how easy and straightforward, excuse me, and intuitive that software is. There are no hidden features in any of it, which just super easy to navigate. Even me, non-physicist, can set up a test queue in a matter of a couple of minutes. The DoseView 1D side of the software includes point measurement functionality, so you can scan your PDI curve, convert to dose, and then drive the detector to the appropriate reference point for your electron beam measurements, all using the same program interface. Now let's get back to the heart of our conversation today, phantoms. So as the 9A recommendation states that you need to have an appropriate phantoms and phantoms for the scope of your stereotactic services offered. Here too, Standard Imaging has a comprehensive suite of phantoms to select from. We work with you to determine which of our Lucy phantoms would be the best fit for your clinic based on your imaging protocols and workflow. For your consideration, we have the Lucy EA, which we will go into depth momentarily. But just to let you know what else we have, we also have our Lucy MR Phantom, which is our fully anthropomorphic phantom. The entire thing is MR visible, which makes it an excellent choice for your Unity system, for example. And we have our traditional, if you wish to think of it that way, most long-standing Lucy 3D QA Phantom, which is very comprehensive and therefore very customizable in the Lucy family. But today, we want to focus on the Lucy EA, since it is our most recent Phantom release and includes some key features that make it simple and quick to use. The Lucy EA Phantom easily fits into your stereotactic patient treatment workflow. By using the Phantom as a patient substitute, you can scan, plan, treat, then verify with minimal setup variation. And what is that you can verify? End-to-end SRS QA, daily SGRT, OSMS, and IGRT QA, positioning and repositioning. daily 6 degree of freedom QA with our optional 6 DOF shift plate, coincidence of radiation mechanical isocenter, daily and monthly radiation isocentricity tests, those Winston-Lutz tests, using one or more of the distinct targets we offer in our inserts. And then, of course, we have film and ion chamber dosimetry with up to 6 targets, 6 distinct targets plus an irregular avoidance structure in the mix. Accomplishing so much with so few inserts, swappable in an open mass system, make Lucy EA ideal for standardization across sites and machines. So a little bit closer detail, the Lucy EA Phantom is pseudo-anthropomorphic. It's made of virtual water, so on the human skin tone spectrum. It is designed to perform comprehensive quality assurance tests, like I said, for your stereotactic procedures. The Phantom allows verification of treatment planning software calculations for volume measurements, distance measurements, and image transfer. And again, that dosimetry verification is accomplished via components that accommodate ion chamber or other detectors and film. The Lucy EA Phantom is toolless and modular with a large brain cavity, as you can see here. Standard inclusion with the Phantom is the multiple target Winston-Lutz insert, as well as the multiple target 3D film insert. Again, has 4 embedded targets in here plus the avoidance structure. An optional accessory is our orthogonal film insert, which has 3 different targets of 3 different sizes along that central axis. And it also includes a solid plug with an embedded target and 1 drilled plug for detector of choice, included with the Phantom, as you can see, insert from the neck. And then it also contains a large sagittal plane that bisects the vertebral structure. Lucy's pseudo-anthropomorphic features include, of course, the eye socket, nose, forehead, and chin, heterogeneities representing sinus and oral cavities, skull, vertebrae, and spinal cord, aid in simple and accurate localization. Lucy EA is typically set up in an open mass system like you see here, easy access to lift off the nose plate, I guess you could call it. So that you can swap out inserts and change solid to drilled plugs in the chamber cavity while that Phantom is immobilized. Alternatively, since the Phantom has a flat base, you can set it up directly on the treatment couch without requiring any additional stabilization fixture. The Phantom's virtual water is easily visible on commercially available SGRT systems, Vision RT, Variance Identify, and CRAD, to name but a few. Here, I just wanted to give you an idea of what the images actually look like. So you've got your CT images, very easily able to contour due to the clarity of the visible targets and avoidance structure, and localization again is made easy with that bony anatomy as well. The multiple target Winston-Lutz insert placed in the Lucy EA Phantom is used to perform the required radiation isocentricity beam alignment verification. And since nobody wants to perform hand calcs anymore, why would you when there's great products out there? You can easily automate your Winston-Lutz analysis using our PIPS Pro Stereotactic module. Before moving on to talk about the rest of what QA Complete includes, I want to take a quick moment to verify, or to summarize how well our detectors plus electrometer plus the Lucy EA are an excellent basis to meet those basic stereotactic QA program goals during commissioning and afterwards for monitoring your SRS program. It is important to keep in mind as you're making a decision about what to use throughout your organization. Sometimes we have physicists that move from site to site. Some certain QA is performed less frequently than others. What is easy to train is easy to maintain. There are very few moving parts with the Lucy EA, so very, very easy to train on. What is sufficient is also efficient. Don't overcomplicate matters when you don't need to. Stereotactic is challenging enough. And what is reliable and repeatable is robust. So you can simply simplify to standardize across Linux and hospital networks very easily with these dosimetry and phantom tools. Now, I would like to talk just a moment about QA Pilot, which is a QA management software, because we all know, or at least I believe we all strive to be, strive for more efficiency, transparency, better risk management, especially when it comes to stereotactic programs. It is important to track trends so that you can easily notice when things change. And I think we generally are all interested in improving on what we do today so that we can be better tomorrow. So QA Pilot, the QA management software program, is tremendously useful as part of your stereotactic and general departmental practice. QA Pilot with PIPS for Autopilot takes your stereotactic QA program to the next level with automation, customization, and oversight tools, so that you have a comprehensive overview of machine QA aspects of your organization. Analytics, machine logs, and instant learning logs provide additional tracking and assessment tools needed to meet process improvement goals. And I'm sure we all have some of those that we're looking to improve on. Now, what about patient QA? Again, here at Standard Imaging, we want to take a holistic approach to patient QA, making sure that it doesn't end with just pre-treatment QA. After all, I continue to say, a few fractions delivered at high dose rates, there just really isn't any room for error. And so the trifecta for us is Adaptivo, iAmSure 3D, and LinApView. And what does that really look like in your workflow? So Standard Imaging's comprehensive patient QA can seamlessly integrate into your clinical workflow, adding valuable automation, efficiency, and data-driven insights, not only for your offline and online adaptive therapy workflows, but for all patients. Traditional QA, patient QA processes, it's once the treatment planning process is complete, the quality assurance process begins. And traditionally, that has meant patient-specific quality assurance includes plan calculation checks, which tend to be less accurate for highly complex plans, and pre-treatment delivery QA, which is usually performed after hours by the physicist using external hardware, such as detector arrays, which have limited resolution and accuracy. Given the ever-growing complexity of modern radiation therapy treatments, and stereotactic in particular, physicists must ensure that their treatment planning system, beam models, and algorithms are fully validated to meet these demands. Standard Imaging's pre-treatment QA solutions ensure a high level of accuracy and precision to provide confidence in that planning and delivery of your advanced treatments. iAmSure 3D plan check software uses a gold standard, research-driven, Monte Carlo-based calculation algorithm to ensure your treatment planning system calculations are checked with the highest accuracy and precision available, giving you the needed confidence in your complex treatment plans. In fact, the Simoca Monte Carlo double check algorithm is more accurate than the dose calculation algorithms used by most treatment planning systems. Adaptivo's epidosimetry pre-treatment module maximizes the value of your existing EPID technology, taking full advantage of the EPID's superior resolution, large field of view, and predictable dosimetric response. Furthermore, it requires no hardware or phantom setup, so pre-treatment QA can be easily performed by therapists with fully automated analysis and reporting. Both iAmSure 3D and Adaptivo have automated analysis, reporting, and email alerts, which empowers physicists to prioritize their time and attention without jeopardizing quality. Traditionally, this is where data-driven, patient-specific QA stops. However, we all recognize that even with meticulous planning and pre-treatment verification, uncertainties in patient setup and anatomy can compromise radiation delivery accuracy. These inaccuracies are particularly critical for high conformal, dose-escalated, and hypofractionated treatments, where precision is paramount. Relying on traditional QA practices like weekly physics chart checks and CBCT reviews, practices that are often subjective and vulnerable to human error, unfortunately, they just simply aren't enough. It's time to set a new standard, and Standard Imaging's comprehensive automated in vivo solutions address modern treatment challenges and associated risks. Adaptivo's in vivo EPID dosimetry module, along with LINAC View's real-time log-based machine performance checks, raise the bar for comprehensive patient QA and risk management. These real-time automated solutions are critical for building confidence throughout the treatment process, ensuring patient safety, treatment quality, and mitigating risks for every fraction. Automated alerts enable clinicians to efficiently assess real-time variability in treatment delivery. Issues with patient setup can be quickly identified and addressed before the next treatment session. Or clinicians may need to do offline adaptive therapy evaluation to accommodate changes in anatomy. Proactive machine QA, that's important. So our LINAC View works alongside Adaptivo to provide that real-time machine performance and plan delivery QA data for every treatment delivery. And this is all automated in the background, and this empowers physicists to stay in tune with machine-related deviations and proactively minimize machine downtime. LINAC View is also a valuable plan delivery QA tool for online adaptive workflows, such as Elekta's Unity workflow. So that really brings me to the end of everything I wanted to share with you today. I know it was a quick overview, but comprehensive, complete solutions to really implement, get you going up and running as efficiently and safely with Stereotactic is what we're here to help you with. So I just want to double check at this time to see if any questions have come in. I'm going to ask my colleague Ashley to help me out with that. I'm not great navigating between my screens. Ashley, do you see anything noted yet?
No questions yet, but if you have them, like she said, just navigate to that Q&A button at the top of your screen and just submit through that, and we'll answer them for you.
Yep. And while I'm giving you a moment to be able to type in any questions you might have, I do want to direct you to other resources we have available. Of course, our website has a wealth of information. If you haven't created an account in our customer portal, I highly recommend that you do so, where you can access even more information than just the standard view on our website. If you want more detailed description, really go into depth on what our QA Complete solution for Stereotactic or other solutions that we have available for your clinics, you can obviously reach out to sales@standardimaging.com. We can set up further discussions, further webinars, and really delve into software and hardware as you need. You can also reach out to me, of course, azens@standardimaging.com. I'm always happy to help, and if I can't answer the question, I know the brainiacs in this company, and we'll make sure that you get to the person that can really help you out as fast as possible. Also wanted to point out that we do have a webinar on December 12th, which will go over QA pilot. Now that can really help your organization find efficiencies, really have a better insight and manage your entire machine QA. There's just so much machine QA you guys have to do, really how you can manage that entire practice. And then for the patient QA, because I'm not the patient QA product manager, I do want to point you to a couple of webinars from my colleague, Vicki Howard. One is the Optimizing Patient QA Workflow, Best Practices and Innovations. And then plenty of you have probably heard about TG307. So she goes into a more depth webinar on TG307 and how that impacts or could impact or improve, really help you improve practices within your clinic. That one is up on our website as well. So last call for any questions. Ashley, do you see anything?
Nope, none coming through.
Well, alrighty then. Well, thank you everybody for your attention today. I really, really appreciate having you here with me today. I wish you all a great Thanksgiving next week if you celebrate that. And wherever you are in the world, have a great rest of your day. Thank you so much. Bye-bye.